Push the red button. If the red button's not on, your mic is not on.
Good morning, and welcome to the Subcommittee on Health's hearing on Native Veterans' access to care. Before we begin, a little business, and I would like to request unanimous consent for Congresswoman Halen and Congressman Gallego to join us for today's hearing. So without objection, and Congressman Giaforte to join us for today's hearing as well. So we welcome the 3 members of the committee and 3 additional members today's committee, and appreciate your attendance very much. Today is a historic day in Washington, D.C., as it is the first time in at least 30 years that either chamber's Veteran Affairs Committee has held a hearing solely on the health care needs of our Native veterans. I know Mr. Bergman had a hearing in his district, but this is the first one in Washington, D.C. In 30 years. American Indian and Alaska Native people have served in the United States Armed Forces since the Revolutionary War, and served without being acknowledged as citizens until 1924. Native people serve at consistently higher rates than any other racial or ethnic group. The rates are even greater for Indian and Alaska Native women, who serve at disproportionately higher rates than Native men and non-Native women. This hearing is different than most this committee holds, as it is an examination not only of VA and the health status of Native Americans, but of VA as a part of a federal government that has a solemn duty to uphold trust and treaty obligations to tribal people. In exchange for land and resources, the United States promised members of Indian tribes safety, economic opportunity, and health care. The federal provisions of health care is not a handout. It is a payment on a debt. And that debt, sadly, has continuously been defaulted on by the United States. It is essential that we recognize this federal obligation does not stop at the doors of the Indian Health Service. It is an obligation of all parts of our government. For that reason, we have called this hearing to hear from tribes and tribal organizations to learn how the VA is meeting its federal trust responsibility and where do they need to do better. We know that while Native people serve more than anyone else, they have the lowest health status of any other race or ethnicity in the United States. Native veterans are more likely to have service-connected disabilities, experience sexual assault and post-traumatic stress, and die by suicide. In 2010, the VA and Indian Health Service established a memorandum of understanding to improve the health status of American Indian, Alaska Native veterans through coordination, improved services, and resource sharing between VA, IHS, and federally recognized tribes. This year, VA and IHS plan to revise the 2010 MOU. We would like to check in on the progress made over the past 9 years, what went well, what didn't, and what is needed in the new MOU to ensure we truly are improving the health status of American Indian and Alaska Native veterans. Before we move on to our first panel, I want to express to you my great disappointment that Dr. Stone, who will be the signatory of this new MOU, is not here today to speak to these issues. Secretary Wilkie spoke many times this summer with several dozen news articles to show for it that Native veterans' access to health care is one of his top priorities. Now, I don't doubt that. I don't doubt his commitment of the program offices. I don't doubt that the commitment of the program offices here today. I know that I'm sorry. Now, I don't doubt the Secretary's commitment. I am concerned about the progress we are making and a successful conclusion to a negotiation with the MOU. And so with that, I would like to recognize Acting Ranking Member General Bergman for 5 minutes for any opening remarks you wish to make.
Thank you, Chairwoman Brownlee. It's an honor to be with you all today and filling in for Dr. Dunn, who is the ranking member. And he and I sat down and chatted about the importance of this hearing. And as you all know, he had a conflict, but he'll be here as soon as he can. In the meantime, it's a great, again, honor to be here in this place to recognize the committed service of so many of our American Indian and Alaskan Native veterans. There is perhaps no better hearing that we could be having as we prepare to return to our districts for the Veterans Day time period here than the hearing we're having today. The numbers show that there is no other ethnic group that steps up to serve the United States in the United States Armed Forces more than Native Americans. My district, the 1st District of Michigan, is home to 8 federally recognized tribes, and their deeply embedded patriotism and commitment to service is a credit to our community and an inspiration to all. As we will learn this morning, Native veterans often face unique barriers to care, and we still have a long way to go in ensuring that they receive the care, benefits, and services that they deserve as veterans. I look forward to hearing about how the Department of Veterans Affairs is working with Indian Health Service, tribal organizations, and other important stakeholders, many of whom are represented here today, to identify, break down, and eliminate the barriers to success. I'm glad to hear that VA is actively working on a new memorandum of understanding with IHS, but that MOU will only be effective if, number one, it includes measurable metrics and improved coordination of care, particularly where referrals to specialty care services are concerned. Number two, is developed with the direct involvement and engagement of those who will be most impacted by it, that is, the Native American veterans themselves. And three, is supported by an ongoing commitment to cultural respect, sensitivity, and trust and relationship building. I appreciate the many tribal nations and communities that are represented here today, either as witnesses or through the statements for the record that have been provided. I'm very much looking forward to listening to your testimony today, and I want you to know that your service has not and will never be forgotten. Thank you for that. With that, I yield back.
Portland Area Representative for the National Indian Health Board. Next, we have Kevin J. Ellis, Chief Executive Officer for the National Congress of American Indians, followed by Ms. Sonia Technowski, Vice President of the National Council of Urban Indian Health. In addition, we're joined by Chief William F. Smith on behalf of the Alaska Native Health Board, and finally, Chief Marilyn Malebra on behalf of the Indian Health Service Tribal Self-Governance Advisory Committee. So with that, I now recognize Mr. Joseph for 5 minutes, and welcome.
Good morning, Chairman Brownlee and members of the subcommittee. On behalf of the National Indian Health Board, thank you for the invitation to testify on health services for Native veterans. Iuhutkini Squeezed Badger is my name. I'm Andy Joseph Jr. I am an enrolled member of the Confederate Tribes of the Colville, and I am an Army veteran. I can speak firsthand about ongoing challenges in Native veterans' health. Native veterans have served in every U.S. military conflict of the past 200 years, yet today's hearing is a first ever on healthcare access for Native veterans. Thank you for this step. On behalf of the National Indian Health Board and as a veteran, I'm disappointed that Secretary Robert Wilkie and Rear Admiral Wilkie will not be here today. Both Secretary Wilkie and Rear Admiral have spoken about their desire to better serve the health needs of Native veterans, and we are counting on them and this administration to Native veterans. The federal government has a dual responsibility to Native veterans on one obligation because of our political status as a Native people and one because of our military service. Our people served in the military at higher rates than any other ethnicity in America. We continue to hold up our end of the bargain. There are many challenges that Native veterans face in receiving quality health care. Please allow me to share some policy recommendations, all equally important. These are discussed in detail in our written testimony. One, tribal consultation can help remedy many issues for Native veterans. We invite the VA to engage in regular tribal consultation with the Native veterans. Two, there are limited options within the VA for culturally appropriate programs and services tailored for Native veterans. That needs to change. Three, make vast investments directly to tribes for Native veterans, mental health care. Native veterans are twice as likely as other veterans to return home with post-traumatic distress disorder, depression, alcohol and drug use disorders are significantly higher among our veterans. The same is true with suicide. These issues and transition from active service back home need sufficient investment. Four, we ask that the VA committee to actively support advance appropriations for the Indian Health Service and other programs. Our people are still suffering from the most recent 35-day government shutdown. It's been a decade since the VA has benefited from advance appropriations. It's IHS's turn. We ask you for your active support. 5, Indian Health Services is a payer of last resort. We strongly recommend that Congress makes explicit in law that VA is required to reimburse IHS and tribes for services under purchase and referred care. 6, Congress should exempt Native veterans from co-pays and deductibles to the consistent with trust responsibility for health care for all Native people. 7, when it comes to health IT modernization, Congress must ensure parity in appropriations and technical assistance to tribes to ensure interoperability between the VA and IHS. It is shameful that Native veterans are forced to hand carry health records between their IHS and the VHA provider. 8, we need a tribal technical advisor committee to the VA. We strongly request that the VA committee favorably act on the bipartisan HR 2791 introduced by Representative Holland. 9, tribal leaders and veterans continue to request that the VA create written guidelines and policies to clarify referral process under the VA and IHS Memorandum of Understanding. The VA has yet to do so. This recommendation also made in 2019 Government Accountability Office. In conclusion, on behalf of the National Indian Health Board, thank you for holding this important hearing. We have a long way to go together to improve care for Native veterans. We will serve as in this way as well. Thank you.
Thank you, Chairman Brownlee and Acting Ranking Member General Bergman, and members of the subcommittee. On behalf of the National Congress of American Indians, I'd like to thank you for holding this important hearing today to discuss the many issues affecting Native veterans across health care. I really do appreciate the comments that everybody's made here today, and also Mr. Joseph. There's a commonality. There's many things we'll touch on together, which shows that we start from a strong foundation of being on the same page. I serve currently as the Chief Executive Officer of NCAI, and I'm an enrolled member of the Forest County Potawatomi community in northern Wisconsin. I look forward to working with members of the subcommittee and a number of members of Congress to better fulfill the federal government's commitment to provide for well-being of American Indian and Alaska Native veterans when they return home. Founded in 1944, NCAI is the oldest and the largest national organization composed of tribal nations and their citizens. Tribal leaders created NCAI in response to termination and assimilation policies that threaten the existence of tribal nations. Since then, NCAA has fought hard to protect and enhance tribal treaty rights, sovereign rights, secure tribal traditional laws and customs of our tribal nations, promote the common understanding of tribal nations' roles in the family of American governments, and improve the quality of life of all Native Americans across the country. American Indians and Alaska Natives, as mentioned here already, have a long history of distinguished service to this country. Per capita, American Indians and Alaska Natives serve at a higher rate in the armed forces than any other group of Americans that have served in all the nation's wars since the Revolutionary War. In fact, in periods when we weren't even U.S. citizens, our American Indian natives participated as veterans for this country. But despite this esteemed service, Native veterans have lower personal incomes, higher unemployment rates, and are more likely to lack necessary health insurance. The federal government's responsibility, as you mentioned, to provide quality health care to Native veterans comes from two places: their service to this country and the federal obligations that are owed to Indian country due to giving up so much land back in the last 2 centuries. The United States must honor its commitments to Native veterans by ensuring federal policy addresses its unique needs. There is no way to accomplish this, though, without us being at the table and being in the conversations where decisions are made. Right now, the Department of Veterans Affairs and the Indian Health Service are negotiating a new memorandum of understanding that will impact Native veterans for many years to come. The VA and IHS must ensure that Indian country has a voice in these discussions so that this next MOU fully addresses the need Native veterans have, regardless of whether they are living on rural reservations or in major urban areas. Ensuring Native veterans are getting the health care they deserve requires communication and cultural competency. On the ground, this means streamlining processes for tribal nations to become tribal veteran service organizations that provide access to culturally appropriate assistance for Native veterans when they are pursuing VA benefit claims. In Washington, D.C., it means passing and implementing legislation that will ensure Native veterans' voices are heard by the highest offices in the VA. Accordingly, I encourage you all and every member of this subcommittee to support H.R. 2791, the Department of Veterans Affairs Tribal Advisory Committee Act of 2019. This bipartisan legislation, which was introduced by Congresswoman Deb Haaland, and would establish a tribal advisory committee to advise the Secretary on how to improve programs and services for Alaskan Indian and American Indian and Alaska Native veterans. In addition to improving engagement with Native veterans, federal policymakers must make it easier for Native veterans to access health care through increased coordination between the VA and IHS system. For reasons ranging from cultural competency to significantly reduced travel times, Native veterans often prefer to receive care at IHS, tribal, or urban Indian organization facilities. Therefore, NCAI calls on Congress and the administration to ensure referrals through the Purchase Referred Care Program and services provided to Native veterans by urban Indian organizations are reimbursable by the VA. Additionally, we must eliminate VA's co-sharing for Native veterans, as the federal government has treaty and trust obligations to provide health care to American Indian and Alaska Native people. Finally, I want to briefly emphasize the importance of advance appropriations for IHS and the Bureau of Indian Affairs. IHS is often responsible for providing health care to Native veterans, and access to IHS and VA facilities often depends on services provided by the BIA. Protecting funding for these agencies from uncertainties in the federal budget process will improve access to vital health care for Native veterans. I want to close my testimony by expressing my sincere gratitude for the service and sacrifice of all the veterans, especially our Native veterans, many of whom are tribal leaders across Indian country. It is incumbent upon us all to ensure the federal government to honor its solemn commitments to Indian country. Thank you again for this opportunity to testify, and I'd be happy to answer any questions when it's over.
Thank you, Mr. Ellis, and I now recognize Ms. Tetnowski for 5 minutes.
Good morning. My name is Sonia Tetnowski, and I'm an enrolled member of the Makah Tribe, a U.S. Army veteran paratrooper, and the CEO of the Indian Health Center of Santa Clara Valley. I'm also the Vice President of the National Council of Urban Indian Health and the President of the California Consortium of Urban Indian Health. UIOs provide high-quality, culturally competent care to urban Indians, which consists of about 75% of all American Indians and Alaska Natives. I would like to thank Chairwoman Brownlee, Mr. Bergman, and other distinguished members of the subcommittee for holding this important hearing. It's my pleasure to testify today regarding H.R. 4153, the Healthcare Access for Urban Native Veterans Act. We ask that the Department of Veterans Affairs fully implement the VA and IHS MOU and reimbursement agreement for direct care services. This action would allow UIOs to be reimbursed for providing health care to AIAN veterans. Most AIAN veterans live in urban areas and would benefit from the culturally competent care provided by UIOs. Despite the history between tribal people and the United States government, American Indians and Alaska Natives continue to serve this country at a higher rate than any other group in the nation. We have a responsibility to protect the land of our ancestors, respect their teachings, and pass that knowledge on to generations that follow us. But I am sad to report that according to a 2014 Minority Veterans Report conducted by the National Center for Veterans Analysis and Statistics, it clearly states that American Indians and Alaska Natives have the highest poverty rate and the highest uninsured rate. This seems out of balance. We serve, we protect, but yet we struggle to have parity in the system. So we ask you to help us complete the ITU system of care. In order to begin to address the health disparities of urban Native communities, I ask that this committee take into account the national healthcare spending average of $9,523 and the $19,228 the VA spends in Santa Clara County per patient served, compared to the $3,688 currently allocated to me to serve that same patient. UIOs are efficient and effective, and we deserve parity. We also ask that medication delivery and dispensing be included in the agreement this time, as many of our veterans are homeless and do not have addresses to receive their medication. As these are our community members, we do what we can to help them overcome these obstacles. The balance of traditional and Western medicine is vital to the healing of many of us, which is why my UIO, the Indian Health Center of Santa Clara Valley, provides an annual wiping of the tears ceremony so that my fellow soldiers and I can stand together and grieve and heal as only another soldier would understand. For many urban Indians, the UIOs are the only place where they can receive cultural and traditional services. So bring parity to the system, and together let's wrap our soldiers in culturally competent care, help us strengthen our ITU system of care. Again, NCUI strongly recommends, pursuant to Section 405C of the Indian Healthcare Improvement Act, that the VA IHS MOU include reimbursement for care provided by the UIOs. I would like to present you with this medicine, which consists of abalone shells, sage, cedar, and sweetgrass, to remind you that traditional medicine has done for me and my fellow soldiers. Our traditions keep us grounded and provide that support needed to heal the invisible wounds that we all have from serving and protecting this country. So with that, I ask you to support my work and the work of all urban Indian programs to bring support for that healing to our communities. Thank you for holding these hearings today and for the committee's support of parity in the ITU system of care and H.R. 4153. My full testimony has been provided for the record, and thank you again for the opportunity to speak.
Thank you, Ms. Tetnowski. I'm not
Tetnowski.
sure why I'm having a hard time with that, but I am. I apologize, but I do also want to thank you for your service. And being a paratrooper is just, it's amazing, and thank you very much. So I now recognize Chief Smith for 5 minutes.
The issue, Adukte, Chief Bill. Good morning, my name is Chief Bill, Chief of the EACS. My mother was the last full-blooded EACS speaker. My father was a World War II veteran. I am also the Vice President of the Valley's Native Tribe, Executive Committee member of the Alaska Native Health Board, and Vice Chair of the National Indian Health Board, and a Vietnam vet. On behalf of the Alaska Native Health Board, thank you, Chairman Brownlee, Ranking Member Dunn, and distinguished members of the House Committee on Veterans Affairs Subcommittee on Health for the opportunity to speak with you today. For the record, I have provided a written statement which gives more background and details on the issues that I can share with you today. I hope mostly to honor our veterans, lift our government-to-government relationships with tribes and federal government involved in the federal trust responsibility, and provide a description of the Alaska tribal health system and our tribal sharing agreements. I, too, am also disappointed that today we are not sitting with Rear Admiral Wiaki, or Secretary Wilkie, or Dr. Stone for this important hearing recognizing the government-to-government relationship and a strong partnership between the tribes and the VA and the Indian Health Service. It is my hope that we'll continue to have tribal representatives on the IHS-VA MOU team. In our written comments, we also provide details on issues included but not limited to support of H.R. 2791 and S. 524, Department of Veterans Affairs Advisory Committee Act of 2019, including tribal representatives on the Indian Health Service and the VA leadership team on renewal the MOUs, reflecting the government-to-government relationships. Review and revise of the VA tribal consultation policy, bill and parlay between the VA and the Indian Health Service, exempt Native veterans from copay and deductions in recognition of the unique political status of American Indians and Alaska Natives on the federal trust responsibility, and I support the tribal veterans representative model. I will like to start with the tribal sharing agreements. Before the agreement, Alaska veterans only had 6 points of access for care through the VA in an area that would cover the lower 48 from coast to coast and from the northern borders to the southern borders. Most vets went years, if not decades, without care. After signing the agreement, veterans for the first time had access to care closer to home, from 6 locations to over 200, with little or no capital expense carried out by the VA. And even non-Native veterans can be served at a veterans hospital that we have in Alaska. And as I was at the recently at the Alaska Native Federal AFN meeting in Fairbanks, tribal delegates shared with the VA need to go out to the cabins. And when I say go out to the cabins, when the VA comes to Alaska, they usually go to the hubs, Kotzebue, Fairbanks, Anchorage, and they say everything is good. What the veterans would like to see is them fly into Dillingham, get off the plane in Dillingham, get down to a skiff and go upriver 50 miles, get out of that skiff at 50 miles, and go on a snow machine or a four-wheeler or a dog sled and talk to that veteran that's in that cabin that hasn't got his share, that's come home from Vietnam, come home from Iraq, Afghanistan, and everything else, and ask him if he's okay. Because they're out there, because I, for one, as a Vietnam vet, took 35 years to talk to my brother that was there before I was, or to even get care from the VA. To share with and we support the tribal veteran representative. The one way to help develop outreach, but support the tribal sharing agreements, often direct access to local communities' care with providing veterans with their families. And that's the only way we're going to get the veterans out of the woods is through the tribal veterans representatives, their aunts, their uncles, their kids that are going to tell that veteran, this is a new VA. This is something that they can come home to. This is something that will welcome and take care of them. Like I say, it took me 35 years to seek help, and I talked to my brother, and he was there. It was a fireworks in Anchorage on the New Year's Eve, and he was sitting there watching it. Next thing you know, he was on the deck. He was not there. He was back in Vietnam. He was out there on patrol, and those were not fireworks. Those were bombs and everything else coming in. That's what we have. We're still 19 years old. We're still in Vietnam. We come home, but Vietnam come home with us. And not only did that, Agent Orange come with us. And if we had to build a Vietnam Wall from the people that passed away since then from the Agent Orange exposure, that wall would be tenfolds. Inclusion, many veterans have broken the faith with the VA system. Some have not access to care in decades. Like I said, tribes in Alaska and across the nation are working with the VA to help restore their faith. In Alaska, we have over 34,000 vets enrolled, and out of an estimated 75,000 to 900,000 vets. More work needs to be done to reach the brothers and sisters when we work together with the VA and Health Service through consultation with recognition of the strengths of their tribes and tribal health organizations. Bringing it to the table, an important step would be to allow us for longer tribal sharing agreements periods, support continuous care over time, allow for tribal representatives to join the leadership teams reflecting the government-to-government relationships, and will provide the best results for the meeting and need to honor our veterans. Alaska Native Health Board thanks the subcommittees and looking forward to further support and members in their work on the veterans' health care issues. And Alaska Native Health Boards welcomes any questions. Thank you.
Thank you very much, Chief Smith, and I thank you also for your service to our country. Last but not least, I now recognize Chief Malerba for 5 minutes.
Wikisk. Good morning, Chairwoman Brownlee, Acting Ranking Member General Bergman, and members of the subcommittee. Natiwi Sunk Squamatai Mutahash. My name is Chief Many Hearts Lynn Malerba of the Mohegan Tribe. On behalf of the Indian Health Service Tribal Self-Governance Advisory Committee, it is a great honor for me to present our testimony before you today. Our formal written testimony has been submitted to the subcommittee for the record. Native veterans, as you've heard, have a uniquely special status with the United States. Our American Indian and Alaska Natives have fought for the U.S. Armed Forces in every war since colonial times. In fact, 39 Mohegan men fought at Bunker Hill. In exchange for the cession of lands, treaties between our Native governments and U.S. included health care for our people. As warriors for this nation, Native veterans are deserving of the best health care we can provide. The VA reports that there are 145,000 Native veterans living in the United States with an average life expectancy 4 years shorter than the general U.S. population, and who are more likely than other veterans to experience social and economic difficulties that impact their health. Tribal nations that elect to administer health programs and services under a self-governance agreement to their citizens are effective because tribal nations know the needs of their communities and are in the best position to provide culturally appropriate solutions to address those local needs. However, THPs are limited due to limitations imposed by the VA. In recognition of the shared responsibility to provide better care, an MOU between the U.S., VA, and IHS was implemented to access VA funding for services provided to our Native veterans. There is a tremendous opportunity for all to work collaboratively to update the MOU and identify components that will ensure Native veterans receive timely access to quality health care, the services that they are owed. The TSGAC strongly advocates for the following improvements. Veterans often require additional specialty services that are not available at IHS or THPs. If a Native veteran needs a referral, that same patient must then be seen within the VA system before a referral can be secured. Veterans are then forced to maneuver a very complex healthcare system. Our recommendation is that the VA should accept referrals made by IHS and THPs to ensure best services to our veterans. Further, the VA should include PRC in the IHS-THP reimbursement agreements to eliminate rationing of health care and delays in care. Native veterans who seek health care services at a VA facility are assessed with co-payments, which is in direct opposition to the federal trust obligation. We recommend the discontinuation of this practice. The VA does not accept provider credentialing from THPs. Our recommendation is that they be accepted by the VA to ensure care coordination is effective and efficient. IHS and THPs have significant workforce challenges, due in part to most facilities being located in rural and remote locations. Our recommendation is that IHS and tribes be included in the planning of the GME pilot program to ensure that any future regulations or policies work optimally in Indian country. Only those IHS and tribal health programs that use the RPMS system have access to CMOP, the Consolidated Mail Order Pharmacy. We recommend that information technology systems experts from both VA and IHS ensure that all systems used by tribal health programs are compliant and compatible with CMOP system. The TSJSC is supportive of quality measures that provide for the tracking of meaningful outcomes. However, we oppose the prospect of developing either data reporting requirements that affect reimbursements to IHS and THPs or that require new collection of data and reporting systems. Our recommendation is the VA and IHS work together and consult with tribes to develop evaluation measures for assessing the progress toward MOU goals. Additionally, the VA should not impose any additional quality programs upon IHS THPs because it is burdensome, costly, and unnecessary due to the fact that there are already quality requirements in place. The VA belongs to a National Health Information Exchange, and it reported to the GAO this year that IHS and THPs could join the exchange to access information about common veteran patients. However, IHS reported to GAO that testing and onboarding costs to participate were prohibitive. We recommend that local VA healthcare facilities work with their local THPs to ensure health information can be exchanged through local health information exchanges rather than one national health exchange. We recommend that the VA work in coordination with tribes to establish a tribal advisory board because we know that those are effective forums to resolve issues in a government-to-government fashion. In March 2019, the GAO reported that the MOU signed by the VA and IHS lacks sufficient measures for assessing its goals. We recommend that federal agencies focus their limited resources on actions that improve the health of Native veterans by ensuring that the measures are focused on healthcare outcomes. They should be measured and developed and agreed upon jointly. In closing, the VA, IHS, and tribal health programs have made progress and have demonstrated a willingness to improve quality access to care for our Native veterans, deservedly so. But as you see in our statement, there still are significant opportunities for improvement. Katsaptom Tamawish, I thank you very much for hearing my comments today.
Thank you, Chief Mallory.
Thank you.
First, want to recognize Chairman Takano has joined us. Chairman Takano chairs the full VA committee, so welcome and thank you for being here. Would you like to make any comments?
Just an opening statement. Good morning, and thank you so much, Congresswoman Brownlee, for holding this important hearing. And I want to thank our witnesses from the National Indian Health Board, the National Congress of American Indians, the National Council on Urban Indian Health, the Alaska Native Health Board, and the IHS Tribal Self-Governance Advisory Committee. And to those of you who served, thank you for your service. It is critical that this subcommittee hears your voices and the voices of the tribal members that you represent. And while we know Native Americans serve at higher rates than anyone else, they also endure the lowest health status of anyone else. This, frankly, is a national shame and a terrible violation of the trust responsibility the United States government is obligated to uphold. We must do better. VA must do more to ensure the goal of improving the health status of American Indian and Alaska Native veterans is accomplished. I am disappointed to see that Undersecretary Dr. Stone is not here. And while I commend the work of the program officers here to testify, I know the needs of all Native veterans cannot be met by these three program offices alone. This must be a priority VA-wide. Again, I can't thank you enough for sharing your time with us, and I assure you that as part of my VA 2030 vision, this committee is dedicated to ensuring marginalized veterans are receiving access to the health care and benefits that they have earned. This is just the beginning of this committee's work on these issues. I yield back, Madam Chair.
Thank you, Chairman Takano, and again, thank you for joining us this morning. And I will recognize myself for 5 minutes for questions. And I wanted to open up by just saying that our Native veterans, in my opinion, should be receiving actually the very best health care in our country because they have been promised from two sources their health care, both from our country in our commitment to the health care of our Native Indians, including our Native veterans, in addition to VA's commitment to our Native veterans. And if you compile those two pieces together, you should be getting the very best health care in our country, and clearly that is not the case. And so it is very clear to me that there is much to work on and much to improve upon, which leads me to the place of the upcoming MOU. And all of you have talked about issues including the advisory committee that Ms. Hallen is leading on, issues around copays, issues about reimbursements for services, the duplicity of services that have been received, but all of these components need to be ironed out and worked through in this new MOU. We've learned a lot over the last 9 years, and now it's time to really rectify that through a successful negotiations with the MOU. So my question is for each and every one of you on the panel, I want to, and this committee wants to be assured that you are at the table for these negotiations. And so if you could comment on that for me, whether you feel assured that you will be at the table or you have concerns about being at the table. So I can just start with, I'm sorry, I don't have my glasses on. We can start with Mr. Mr. Joseph.
Well, I'm glad that you're asking the question, and to in part of my testimony, with IHS funded the way that it is, it's discretionary, and the recent government shutdowns that I spoke to in my testimony really impact the services that would be provided to any of our veterans that come to our facilities, be it IHS or a tribal facility. It would be really good to be at the table, when they're making those recommendations. I testified in a Senate committee on veterans, prior to the MOU being put in there, and one of my asks was that the VA set up an office of Indian Affairs in the VA, and they did that. And then the second one was to have the VA deploy doctors and nurses to our facilities, because the IHS is so far behind in actually having healthcare providers to provide the services, and the HR system that they deal with is causing a lot of issues, on getting good quality providers that come to IHS facilities. So,
Mr. Joseph, thank you. I only get 5 minutes myself, so I want to hear from all of the others on the panel, but I want to make sure whether you have a sense of whether you would be at the table for these negotiations around the MOU.
I imagine the National Indian Health Board would definitely have someone at the table there. Thank you.
Thank you. Mr. Ellis?
Yeah, Chairwoman. So my answer is I certainly hope so. I don't feel comfortable right now with the situation, and as Mr. Joseph mentioned, there's other organizations that certainly are plugged into this. I will say this: consultation should be going on right now about this. It's been the practice where, these things get put together, these agreements get shaped, and then they bring them to Indian country after the decisions have already been made. I'll also note that the March 2019 GAO report mentioned that there used to be 12 work groups that discussed this, and tribes only participated in 3 of them, but at least they were participating. Now there's 3 work groups, and there's no tribal participation. So that there's some level of concern for us there, that in the crafting of this language, addressing the issues that we all addressed today and that you acknowledge are properly being discussed at the table.
Thank you, sir. Ms. Technowski?
Thank you. We would welcome the opportunity to sit on the panel and be a part of a working group to discuss the parity issues that we continue to have in serving our Native veterans in the urban community. Thank you.
Thank you very much. Chief Smith?
Yes, that would be the right thing to do if we could be on the panel to help, because when we had the MOU in Alaska with the VA, they come to the Alaska Native Health Board, and we had consultation. And I can tell you right now that it worked out great, because my doctor I have had with the Indian Health Service for 15 years, and with the VA I've had 3 doctors in 1 year. My doctor knows me at the Indian Health Service, but the VA also needs to pick up their fair share, because it's something that I earned, and it can make our Indian Health Service money go a lot farther for those that don't earn it. So yes, if I could be there, I'll be there.
Thank you, Chief Smith. And Chief Malerba?
I hope so, but I'm not sure that that's the case. I don't know that we've been giving any assurances about that, but I will say this. Consultation is more than just asking the question. Consultation is actually doing something with the information you receive during consultation. Had the VA and IHS listened to the previous consultations around these topics, we probably wouldn't be sitting with you today talking about the ways that we can improve this program.
Thank you so much. And I have very little time left, but I do want to mention that a constituent of mine in my district is a dual user of VA and the Santa Barbara Indian Clinic. I'm from California. And he uses, as it seems like a lot of Native veterans do, he uses the clinic, the Indian Clinic, for his primary care, and then uses the VA for his specialty care. But we know that his records are not going back and forth, and they seem to have, the VA providers specifically have limited to no understanding of his cultural needs. In fact, he told me and he told my staff that when he went to the VA staff responded by, "I didn't know Indians lived in this city." And so this whole issue of cultural competency and a welcoming from the VA, I think really does need to be addressed, and I certainly would like your feedback on it, but my time has expired. But we can have further conversations about that offline. And so I now welcome Dr. Dunn and recognize Dr. Dunn for 5 minutes. Thank you for joining us.
Thank you very much, Madam Chair, and I apologize for being tardy. We have another committee meeting scheduled precisely the same time, and I want to thank General Bergman for sitting in for me. Thank you very much, General Bergman, and with that, I'll yield the remainder of my time to General Bergman.
Thank you, Dr. Dunn, and thank you, Chairwoman Brownlee. You know, it's God puts us where He wants us when He wants us there. It's up to us to figure out the why. Listening to your comments, I know why I was here today, pinch hitting for Dr. Dunn at the beginning, is to hear your words. And Chief Smith, thank you for your service. Welcome home. And as I look at our fellow Vietnam veterans, because you mentioned something that the Vietnam Wall, I'm not going to ask you to provide comment, but I'm guessing I'll maybe get some nodding of heads that maybe, not maybe, I know for a fact that as a country, if we'd have started welcoming our brothers and sisters home 50 years ago, we wouldn't have some of the mental health, depression, suicidal issues we have amongst our veterans, period, from Vietnam, but especially those tribal members. And right now we're trying here in the committee as a whole to get the Improve Act, which is a bipartisan bill that Representative Chrissy Houlihan and I have put out there, to get it to the committee, to get it out there so that we can reach out to, I'm guessing your tribal members are the majority of that 70% of the veterans outside the VA system who take their lives on a daily basis. And the purpose of the Improve Act is to reach out and make contact with you and your tribal members. Now, having said that, when you try to put something into place, we have a lot of acronyms in the world, and you know, I like logjam. We all can visualize what a logjam is. Well, in this case, it's layers of government is the log. And when we start putting in new layers, we don't necessarily increase output or in better results. So would any of you care to comment on what's preventing the VA and the tribes from sitting down and hammering out for specific credentialing metrics so we can get providers credentialed in both sides? Anyone care to comment?
I know when I meet with the VA and I meet with the Indian Health Service, what I tell them to do is to tear down their towers. They got to work together. That's the most important thing. To me, I see two different towers, just like I see with the VA. There's three. But the VA and the Indian Health Service needs to remove all of their walls and start working together to helping our Native veterans. And like you say, on our Vietnam brothers and sisters, yeah, it's nice to be welcomed home, and that's why we're there when the rest of our brothers and sisters do come back from war, because we will never want that to happen to any other generation ever again. But my main thing is, they started the listening sessions, but it needs to go farther than that. They need to tear their walls down and work together to help our people. That's my opinion.
Thank you very much. And I yield back. Well, before I yield back, we've already made some progress in my district with trying to figure out ways. You got the tribal health clinic, you got extra office space, you got different things. Why can't we combine Indian Health Services, VA services? Because when you live in not only a rural district, but a remote district, that can be a center of healthcare for the entire population run by the tribe. So anyway, thank you. I appreciate the time, and thank you for allowing me to be in here, and I yield back.
Thank you very much. Mr. Cisneros, you're recognized for 5 minutes.
Thank you, Madam Chairwoman. Thank you all for being here today. You know, I became aware of a report of a Native American Marine Corps veteran who was denied being put on the transplant list for a kidney. And the reason that was given was a cognitive impairment, basically because I guess a test that he was giving saying that he wouldn't be able to remember the care that he needed to be able to provide to himself. But after investigation, he did eventually get the transplant, get on the list, but it took so long because of this. And when they found out, they investigated, was that there was, the reason he was denied was because of this cognitive impairment, but really what it was it a barrier, whether a language barrier or a cultural barrier. Have you all seen other examples of this where people are being denied treatment, especially whether it be a kidney or a liver, something that they need because of this cultural bias? Anyone?
I don't know if it was a culture and everything else, but I know that it was too late for my brother because he needed his lungs. He passed away in 2017. We couldn't get him healthy enough in Alaska to transport him to the lower 48, secondary to Agent Orange exposure. He took his last breath and his lungs just quit working, and he didn't get well enough to be able to have me transport him down to Seattle to get a new set of lungs. But there are things in there like, oh, you need to get down. He was at 209. He had to get down to 200 pounds, they said. For 9 pounds, my brother could have lived 5 more years with a new set of lungs. But we couldn't get him well enough when he went downhill to get him down to Seattle to get a new set of lungs. That's all I can say. And he was my hero.
Well,
So Congressman, no specific situations, but the scenario that you point out is common across Indian country in a lot of different areas. And when you look at not taking the, agency folks or the government not taking the time to look at the uniqueness of these communities, you know, not only the location, but the traditional customs and culture and the language barriers that could exist that aren't taken into consideration. It's definitely an issue with treating our veterans that especially might have, you know, brain injuries or head injuries and revert to their traditional languages because it's much easier to communicate because that's how they were raised. We see this with healthcare. We see it with voting. We see it with you know, signing up to all that kind of stuff. Is we need people to pay more attention and to take the time to learn about the uniqueness of our communities in a way where they can connect, we can connect, and things can get accomplished.
Yes, ma'am.
Well, and I think that that's what we were talking about before. When we have to refer somebody outside of our system, you don't have anyone helping them to navigate that system. Whereas if you are within the tribal health program or the IHS system, you will have people there that are culturally competent, that can understand what some of the barriers are to that person accessing care. And sometimes it is that they just have a reluctance to go outside their own community. And so I think that that's why we want to make sure that we don't have to send them back into another system for a referral to care, because chances are likely that they won't access that. They'll just give up and they won't access that care.
Right, and just I'm I got 1 minute left here, but just to follow up on some other things, you've all talked about the MOU between the VA and IHS. In some of these remote areas where there is no VA, you know, and veterans are going there to seek services, have we had situations because of lack of the MOU where they've been denied services or that the VA has said we're not going to pay for that service because they aren't enrolled? And anybody can answer that one. Go ahead. Yes.
We've had situations where the VA won't accept our referral, similar to what Chief Malerbo was talking about, is that the VA, it's hard enough to get our veterans to come to any facility to seek that additional support. And once we have to then transfer them out of our facilities into another system without a patient navigator or a tribal navigator inside the system, we tend to lose them in the process. And many times, even as an urban facility, our nearest VA hospital is about an hour and a half to 2 hours away. And so during that time, without that referral acceptance, we lose them in the process because they don't want to go again. It's like a lot of the response that I get is, I already went through those tests with you. Why do I have to go there and do it again? And that's a fair statement. We should be able to transfer our medical records into the VA system and not put our community members through that again.
Right.
One of the things with the MOU is that it limits the services that non-Native veterans can access at IHS, even though typically we would allow certain services that covered. They don't allow non-Native pregnant women with Native children to access care there, even when they are connected to the veteran, and especially in cases where the IHS and THP are the only facility in close proximity to the veteran. So we think that we need to make sure that all services are covered and that they're not limited, because in some cases, those are the only facilities that are available.
If I may make one more comment, this is the importance of really looking at the regulatory burdens that are in the way of tribes with respect to tribal veteran service organizations, and being able to put those up. The tribes have to go through so much. They have to establish and fund an organization before somebody can get accredited to be able to manage that and work with the community folks on going through the process of their claims and tracking their services. So there really needs to be a look at that.
All right. Oh, go ahead, Chief Bill.
Yes, the other thing too is, like Alaska has over 70 to 90,000 veterans, and only 30,000 of them are registered for their health care. A lot of them are Vietnam vets, and a lot of them that have not trusted the VA enough to come back to the system. And that's where we need to have the tribal veterans, our veterans, being able to talk to them and saying that this is the new VA. They earned everything that they had, but they have never trusted the VA enough to come back to the table. And that's half our veterans up in Alaska are still in the bush and still need to come home.
All right. Well, I'm out of time, but thank you all for your answers. Thank you.
Thank you, Mr. Cisneros. Mr. Lamb, you're recognized.
Thank you, Madam Chairwoman, and thank you to all the witnesses for making this long trip here to educate us. I had a question to begin with for Chief Smith. In your testimony, I noticed you talked about exempting tribes and THPs from the establishment and consolidation of the community care networks. Are you referring to under the Mission Act? Yeah. Sorry, I didn't
Yes.
catch you off guard there. Could you just talk me through, to the extent you're able, what impact you see the Mission Act as having on the Alaskan system and on your tribes and community, if any, if you think there should be interaction based on the Mission Act, or if everything's supposed to be separate? I'm just trying to see where you stand on that. Thank you.
As a veteran, from the Mission Act to the Choice Program to everything else, it's just another thing coming down the pike to us. And as a veteran, we just have to see how it's going to work out, because what we need is health care. And like we've been talking about health care between deals, because I can get my blood test for my diabetes, secondary to Agent Orange exposure, and I can get it in Indian Health Service, and it costs thousands of dollars, and I have to go right across the street to the VA in Anchorage and get the same tests. And I have to travel 300 and some miles to get to my nearest VA. That's a little bit shorter than my dad did. My dad had to go to Portland, Oregon from Cordova, Alaska to see the VA when he passed away. But as a veteran, it's, you know, the Mission Act, the Choice Program, everything else, what the veteran needs to do is being able to treat it where the veteran knows he's going to get the best service for himself or herself. Is that closer to home? Just like we were talking about the MOUs, if you lived in Dutch Harbor, Alaska, it cost you over $1,500 to fly one way into Anchorage, and then you need an escort, and then that's the VA's picking it up. But if you get treated right at Dutch Harbor, if you get treated with your doctor, you don't have to pay that travel cost, and that veteran gets treated closer to home. Not everybody likes to go to the big village just to spend the day.
Yeah, I think what I was trying to figure out was, could the Mission Act, and anyone can answer this if they have an opinion, could the Mission Act be a vehicle for basically saving you that trip and helping you get care in your actual community if the VA had already made that provider part of their network? Is that a possibility, or is there something that
It would be a very good possibility, but the last time I used my VA Choice, when I first got given my VA card, I had to have a scope job, and it cost me $1,500 by using the VA myself. So I have no, I need it in writing first that the VA is going to pick up the bill, because I tried it, and so has a lot of other veterans. So we need to be able to know that they're going to take care of us.
So it all goes to how the network is designed and implemented. And if we could, Ms. Tednowski and then Chief Malerba, and then I'll probably be out of time. So,
Just a quick comment on that. The choice system tends to be the place where the VA refers us to, and at the end of the day, more often than not, it's already out of money. And so we end up with what happened to Chief Smith there, where they want you to go there, but it's not available. And so, again, another barrier. Now it becomes the veteran's responsibility to cover those costs, and they're supposed to be receiving this service as part of their benefits for service.
okay, got it. Thank you. Chief Malerba?
I think that's where credentialing comes into play. If there was reciprocity and full faith and credit for the THPs and IHS providers, then there would be no barrier.
Right. So whether that happened through an MOU or the Mission Act, I guess that's what I was trying to figure out. Does it make a difference? It sounds like probably not. Mr. Joseph?
You know, I think it would be really good if you know, an MOU or the act, if you pass an act that would shift the funds directly to IHS or to tribes to allow our providers to be able to provide for our veterans. Like Chief Smith talked about, some of our veterans are were forced to go to war and drafted, and they don't trust VA. The new VA sounds really good, but a lot of our people want to be seen at home by the providers that they're used to, and if you compared the IHS budget to what the VA gets per patient, you would see a big difference in the need for the IHS to have the funding. You know, I spoke about the government shutdown and the impacts there.
Right, I noticed those numbers in your testimony as well. Thank you very much. I'm out of time. Madam Chairwoman, I yield back.
Mr. Gianforte, welcome. And you've just sat down, but because we're trying to go back and forth, you're recognized.
Thank you, Chair. First, I want to thank you and the ranking member for letting me join this hearing, and thank you for our panelists here today so we can learn more about this subject. I appreciate the opportunity to speak with you regarding Native American veterans' access to health care. Native Americans make up nearly 10% of Montana's population, and they overwhelmingly answer the call to serve. This is why I've introduced the bill in front of us today to ensure our Native veterans have access to the care that they deserve. In 2012, the Indian Health Service and the Department of Veterans Affairs established a reimbursement agreement which allowed rural IHS providers to supplement VA care. In classic Washington bureaucratic fashion, urban Indian health centers were left out of the agreement. In Montana, urban Indian health centers provide care to 60% of Native Americans who are not located on a reservation. My bill, the Health Care Access for Urban Native Veterans Act, will ensure that our Native veterans have access to care that works best for them and will cut wait times at VA clinics for all veterans. This committee has worked tirelessly to ensure we keep our promise to our veterans who have sacrificed so much for this country, and my bill continues this good work. Ms. Tetnowski, urban Indian centers receive limited funds from IHS to provide their services. What would be the impact on these urban centers if they were to receive reimbursement from the VA?
Thank you so much. The impact would be significant. As you stated yourself, 60% in Montana receive services at their local urban center. Same goes with my facility in Santa Clara County. We provide support. We have 41 urban Indian health centers throughout the nation, and these centers provide that support where a tribal facility may not be located. And in most cases, these urban centers are located in places where relocation centers occurred. So that was the purpose of creating our urban health centers. And I think the impact would continue to allow us to provide that culturally competent care and increase our ability to meld both traditional and Western medicine to provide the support that our veterans need in these urban centers. Thank
Okay,
you.
and we have 5 of these centers in Montana, in Missoula, Great Falls, Billings, Butte, and Helena. So if this bill became law, you're saying they would be able to better care for our Native veterans. Okay. One follow-on question, if I could. What has been done to leverage telehealth in any of these centers? Is that something that you're looking at, and what impacts have you had?
We have attempted to get through the process to allow telehealth to be available in our urban centers, but many of our urban health centers have capacity to continue to serve, so telehealth, other than specialty care, may not be necessary. Most of them have behavioral health services. We have medical and dental and other support services inside our facilities. But telehealth would add an additional ability to get that specialty care to those urban centers.
Yeah, and this is, I've been advocating for telehealth because we have many rural communities. We can't have every specialist in every community. Telehealth is a way to provide better care at higher quality. I would just...
It would be a wonderful way also for us to continue to partner with our local tribal communities as well to provide support for each other.
Yeah,
because
and again,
we're one community.
not to substitute for local care, but it's just an enhancement. So I just want to thank the chair and ranking member again for letting me join this hearing today, and I yield back the remainder of my time.
Thank you, Mr. Gianforte, and I thank you for raising the important issue around our Native veterans who live in cities, because I think it's abundantly clear that we are not servicing them the way they need to be serviced. And we've got a lot of work to do in that area, so thank you for bringing that up. Mr. Sablon, you're recognized for 5 minutes.
Yeah, thank you very much, Madam Chair. Thank you very much for holding today's hearing. And to the witnesses, I know what it is to fly distance to come to Washington. I live the furthest away from Washington, D.C. as a member here. I live out in the Northern Mariana Islands, in that part of a place called Micronesia. That's a bunch of over 3,000 islands spread out over the size equal to, if not larger than, the 48 contiguous states. So talk about remoteness, yes. I'm very remote as well, so thank you for coming. A friend of mine, actually, a personal friend who lives on Saipan, actually is on contract with a company that he's a physician assistant, and he provides his services. He's on contract and assigned to a part of Alaska where he provides health medical services to residents of that particular, so far away removed. I think he said you can actually see Russia from where he's at. So I don't know if it's just for Native Americans, but I think it said it's for the residents of that village, smaller area, but so far removed. I looked at the fact sheets about some of the culture with Native Americans have. We have the very same culture where if, say, my father were to be giving me a lecture on something, even if I think he's wrong, I would have to keep my mouth shut and allow him to tell me what's on his mind. And for many times, I thought I was smarter than him, and now I know that actually no, he was smart, much smarter than I am. And you know, our history is so far back that we go through oral history that when Western civilization was still trying to find the spices so they could cure their meat, my people were already traversing the wide open ocean based on nothing but the stars and the currents, and they were traveling. When Ferdinand Magellan got lost at sea, he landed on Guam, and one of the things he found, according to the log of the priest who was on board, was rice. That we had rice in the Mariana Islands, when rice was supposed to be exclusive to Asia. But so much of your culture is in my culture. Let me also thank the chairwoman, because I think this is one of the very few times when we have a hearing for our Native Americans. I am not fully immersed in the VA issues for Native Americans. I am immersed, much more immersed in the issue of Indian education. I chair the subcommittee on elementary and secondary education, and the BIE, the Department of Interior's Bureau of Indian Education, the services they provide in terms for Native Americans is a disgrace. It's a shame, where there would be school facilities in some of the coldest part of the country, and they would have buildings that have heaters that don't work, or that they would not have enough tables and desks for students, and the schools are in complete lack of maintenance, and it's a disgrace. And if the VA provides as much service to Native Americans as they do for their BIE, then we got a lot of work ahead of us. But I came here to thank you for being here today. I am also actually in a markup on higher education, so I would need to leave, but I just came to thank you guys for all of you for being here. And I know that there's a VA representative in the room. So we've got a lot of work to do. And thank you for, Madam Chair, for holding today's hearing. I yield back.
Thank you, Mr. Sablon, and I had the privilege to travel to the American territories with you, including going to your home in the Mariana Islands. And I will just say that there are very many parallels in terms of the challenges of delivering health care in our territories, very similarly to the challenges we're facing with our Native veterans. So
Right.
we have a lot of work.
Yeah, and Madam Chair, if I may interrupt, if I may, actually, and I'm not taking credit for what happened, but it was not until I got elected to this office that the VA actually set up a VA fee-based, contracted a doctor, a physician to provide services to veterans. And sir, you're right, our Vietnam veterans, for some reason, they refuse to sign up with VHA. I have had resource fairs. When Choice happened, I brought the CEO of Choice. We had 20 providers, we increased that to 81. But for some reason, sir, my Vietnam veterans also, and others after Vietnam, they don't want to sign up for VHA, and so I'm having a really tough time trying to get a CBOC established in my district. But I'm not going to give up, and thank you, everyone. Madam Chair, I'm being disrespectful. That's not allowed in my culture and in Native American culture, but I apologize profusely, and I thank you.
Very respectfully, your time has expired, and I will now recognize Dr. Dunn.
Thank you very much, Madam Chair. Chief Smith, during my time in service in the Army as a surgeon, I interacted with a number of different IHS systems around the country, and one that seemed to work better than most, in fact, quite well, was the health and dental services in Alaska. And it strikes me that that's an area where there's more challenges, not less challenges, than perhaps in other areas. And I wonder if you'd address for us, you know, what you do to integrate that kind of care, make that work so well in Alaska in such many different tribes, a lot of area to cover, both urban and remote. And what can we learn, what can we take away from that for the rest of the country?
Talk to us, consult, and work with the Indian tribes to work with the health services. That seems to work. I know when Susan Yeager come to the Alaska Native Health Board to talk about health issues. And, you know, we're trying to do things like dental aids to start a program so we can teach our people how to do it, because there is not enough dentists up in Alaska to take care of everybody. So we have dental aides that go out and take care of our kids with teeth. I mean, when I was a kid, they just put a temporary filling in with the stainless steel pins, and about a week later, the temporary nickumpucky that they put in there dissolved, and then you had to take a file and file off the little stainless steel pins. And now today, you can get new teeth and better care. And one dentist told me, he says, if he could do something for the villages, he would stop at the airport and he would destroy every can of pop that was ever delivered out there. And I agree with him. There's education. They just need to know that it's better to drink the water than it is to drink the soda. And, you know, it's back to nature and back to our deals. And I just want to make one more comment to this gentleman over here about Vietnam vets. It's probably because of the way we were treated when we come home. And it's hard to bring a veteran back to the table, a Vietnam vet. It takes another vet to talk to him, and it takes another grandchild or whatever to drag that grumpy old Vietnam vet out of the woods to saying, you got to come back because you are dying, and this is the reason, and they can actually help you today, and welcome home. But up in Alaska, just consulting with the tribes and deals on health care, because with the Alaska Native Health Board, we have 229 tribes, and we talked together to work on our health issues. And I know down here, trying to follow some of our programs that we started up there, and it works. The only thing that I would appreciate it if it works in Alaska and you bring it down here, don't do too many changes and send it back to Alaska, because we already worked out the bugs.
Thank you very much, Chief. I appreciate those insights. I remember being sort of impressed with how well it was working there. Obviously, there are some hiccups, and you've highlighted that. But thank you very much. And with that, Madam Chair, I yield back.
Thank you, Dr. Dunn, and welcome, Mr. Gallego. I understand that you have questions for the second panel, so we're going to proceed there, and I want to thank the panel for being here, each and every one of you. We appreciate it very, very much, and your testimony helps to really raise all of the issues that need to be wrestled with, and helps to raise awareness not only for this committee but for the entire Congress on the issues that we face. So we appreciate your presence very, very much. Thank you. So I will excuse you, and the second panel will join us. Thank you to the second panel for being here this morning. We are joined by Dr. Cameron Matthews, the Deputy Undersecretary for Health for Community Care for the Veterans Health Administration. Accompanying her is Dr. Thomas Klobuchar, the Executive Director of the Office of Rural Health at the Department of Veteran Affairs, and Stephanie Birdwell, the Director of the Office of Tribal Government Relations at the VA. And joining us from Indian Health Services is Benjamin Smith, the Deputy Director for Intergovernmental Affairs. And with that, I now recognize Dr. Cameron Matthews for 5 minutes. Welcome.
Good morning, Chairwoman Brownlee, Ranking Member Dunn, members of the subcommittee, tribal leaders, and tribal representatives. I appreciate the opportunity to discuss how care at the Department of Veterans Affairs and our partnership with Indian Health Service positively impact our Native veterans. I am accompanied today by my colleagues, Ms. Stephanie Birdwell, Director for the Department of Veteran Affairs Office of Tribal Government Relations, and Dr. Thomas Klobuchar, Executive Director for Veterans Health Administration, Office of Rural Health. I'd like to tell you a little bit about my background, as you can understand why healthcare for Native veterans is so important to me. I'm a family physician from outside Philadelphia that has focused my career on helping vulnerable populations. From my work in correctional health to community health centers, I value the relationship with primary care and seek to expand access to care for those communities that are faced with disadvantages and inequities. I've trained and worked in Chicago, and I'm very familiar with urban health issues, racial and ethnic health disparities, and the impact of social determinants of health. As an advocate for my patients and communities, I am here now at the VA to listen, learn, and serve those who have served our nation. Of a special note, I'm proud to have visited the Alaska Native Tribal Medical Center in May of 2018 and was indeed impressed by its amazing services. As Secretary Wilkie has shared during his meetings with Native American veterans and tribal leaders across the country, our goal at VA is to shorten the distance between people in need of veterans services. While the Secretary and Executive in charge could not be in attendance today, I am proud to be here on behalf of the Department discussing such a vital group within our veteran population. Native Americans have participated in every American conflict dating back to the Revolutionary War, and they serve in the military at a higher per capita rate than any other ethnic group. The importance of Native service members has only grown in this country over time, and we strive to honor this community with the quality, culturally competent care that they deserve. As Secretary Wilkie recently stated, we at VA will continue to provide vital reimbursements to tribal health programs and Indian Health Service. To that end, a Memorandum of Understanding, originally signed in 2013 and updated again in 2010, established the Indian Health Service and VA can coordinate, collaborate, and share resources between the departments. This partnership resulted in the establishment of shared goals, and in order to achieve said goals, VHA has piloted and subsequently adopted several programs. In 2012, VA started establishing reimbursement agreements with Indian Health Service and 114 tribal health programs so far in order to address access to care, achieve effective partnerships, and ensure the availability of resources. In addition to these reimbursement agreements, local VA medical centers have established, where appropriate, several agreements with tribal health programs and Indian Health Service facilities to deliver telemental health to Native veterans. The program serves tribal communities through Indian Health Service facilities in Alaska, Montana, Wyoming, and Oklahoma. The Office of Rural Health Veterans Rural Health Resource Center in Salt Lake City has an active portfolio of innovations in Native veteran healthcare, including the creation of a Rural Veteran Tribal Navigator program that will connect Native veterans with the benefits and care they have earned. Furthermore, the VA Video Connect pilot program is currently being deployed nationwide. VA Video Connect will allow rural Native veterans to access VA healthcare in their homes or local communities via cellular or wireless capabilities. The Office of Rural Health is currently working to tailor this program to Native veteran communities, creating a model that will weave together Western medicine, traditional Native healing, and rural Native community strengths through 4 main components: mental health care, technology, care coordination, and a tailored implementation facilitation strategy. In addition to these programs, the office is also piloting programs to establish tribal VHA partnerships in suicide prevention and developing content regarding Native veterans in the VA Community Provider Toolkit. While the 2010 MOU has opened the door to these great successes, the March 2019 GAO report cites challenges in obtaining the MOU goals, specifically around establishing targets for outcome metrics to assess progress. Thus, in fiscal year 2019, VHA and Indian Health Service MOU leadership agreed that the 2010 MOU was no longer meeting the agency's needs and required modification to create the flexibility needed to move the interagency relationship forward to a new level. To address the shortcomings associated with the 2010 MOU metrics noted by GAO, VA and IHS have brought in metrics experts from each agency to the MOU development process. Once the draft is finalized and tribal consultation, most importantly, is complete, the process of creating new targets and metrics to meet the requirements outlined by GAO will take place as new programs and pilots are developed under the new instrument. We are confident that the evolution of this MOU will be successful, as it is happening in tandem with the Mission Act. This transformative legislation will entail the most comprehensive change in VA's history. The Mission Act consolidated community care programs, as you know, to make it easier for all veterans, families, community providers, and employees to navigate. The health and well-being of our nation's veterans is of utmost importance. We strive consistently provide high-quality care to all veterans and continue to make significant strides in enhancing the practice and culture of the department to be more accessible to our Native veterans. Working with many diverse sovereign tribes is essential to successfully achieve the goals of the MOU. VA is committed to ensuring that our goals align with IHS and that the needs of our Native veterans are met. I apologize for going over, and I do thank the committee for hosting this hearing, and I want to thank the tribal leaders and tribal representatives and all valued partners here who joined today. My colleagues and I are prepared to answer any questions that you have.
Thank you, Dr. Matthews. And I now recognize Mr. Smith.
Good morning, Chairwoman Brownlee, Ranking Member Dunn, and members of the subcommittee. My name is Benjamin Smith. I serve as the Deputy Director for Intergovernmental Affairs at the Indian Health Service, and thank you for the opportunity to testify on Native veterans' access to health care. I want to begin with the Indian Health Service mission, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. As an agency within the Department of Health and Human Services, the Indian Health Service provides federal health services to approximately 2.6 million American Indians and Alaska Natives from 573 federally recognized tribes in 37 states through a network of over 605 healthcare facilities that include hospitals, clinics, health stations, and other facility types. The American Indian and Alaska Native population experiences health and other disparities that disproportionately affect their quality of life. American Indians and Alaska Natives have an average life expectancy of 5 years shorter than that of the U.S. General population, and are more likely than people of other races or ethnicities to experience social and economic difficulties that may impact their health or wellness, such as lower income, lower educational levels, and higher unemployment. As health needs change, new approaches to care emerge. The Indian Health Service, the Department of Veterans Affairs, and our tribal partners will continue to combine expertise, resources, and efforts to assist the nearly 145,000 American Indian and Alaska Native veterans living in the United States. The Indian Health Service and the Veterans Affairs, Veterans Health Administration continue to work to provide eligible American Indian and Alaska Native veterans with access to care that is closer to their homes, promote cultural competence and quality health care, and focus on increasing coordination, collaboration, and resource sharing between our agencies. One way that we're doing this is by revising the Indian Health Service and VA Memorandum of Understanding that was most recently updated in 2010. We have a goal to revise the MOU by fall of 2020 and to look at updating the related performance measures. And we plan to do this in using consultation and by conferring with urban Indian organizations. We want to underscore that this collaboration really started back in the late 80s when Congress directed both of our federal agencies to explore the feasibility of entering into an arrangement for sharing of medical facilities and services. And this requirement was actually memorialized in the Indian Healthcare Improvement Act. Our results were reported to Congress, and our coordination led to an initial memorandum of understanding that was executed in 2003. After close to a decade of collaboration, we updated the memorandum of understanding in 2010, and in that same year, the Patient Protection and Affordable Care Act was enacted and permanently reauthorized the Indian Healthcare Improvement Act. And this act authorized Indian Health Service to enter in or expand arrangements for the sharing of medical facilities and services between Indian Health Service, Indian tribes and tribal organizations, and the VA. The law directs the VA to reimburse the Indian Health Service, Indian tribes, or tribal organizations for services provided to eligible beneficiaries of either department in the respective facility. Since implementing this provision in 2012, and that's the reimbursement agreement authority that I'm citing to, VA has reimbursed over $103 million for direct care services provided in either Indian Health Service or tribal health programs, covering approximately 10,645 unique American Indian and Alaska Native veterans. Currently, Indian Health Service and VA operate under a national reimbursement agreement, so that includes over 70 of our federal IHS-operated facilities. And as we just heard, there are 114 tribal health programs that have entered into individual reimbursement agreements under this authority to be reimbursed for direct care services. We believe in the 5 main goals, which are to increase access to care and services for American Indians and Alaska Native veterans, to promote patient-centered collaboration and communication, to improve health promotion and disease prevention, and to consult with tribes at the regional and local levels, and to ensure appropriate resources are identified and available. And we look forward to any questions that you may have as we are here today before this committee. Thank you.
Thank you very much. Thank you both for your testimony, and I will recognize myself for 5 minutes. The first question I have is to Dr. Matthews. In your written testimony, you said that in early fiscal year 2019, the VHA and IHS leadership team agreed that the 2010 MOU was no longer meeting the agency's needs and required modifications to create the flexibility to move the interagency relationship forward to a new level. You said that the leadership team drafted a new MOU and conducted a first listening session with tribal leaders on May 15th of 2019, and then you go on to say that that tribal input from the session was incorporated into the draft MOU. And so, and as this additional input is now being considered for inclusion in the draft MOU. So I'm curious to know, what was that input? You said that you got a lot of input, but you didn't say what the input was.
Great question. I'm going to defer to my colleague, Dr. Klobuchar.
Thank you for that question. The tribal consultation was conducted in concert with the Indian Health Service in Albuquerque, and many of the questions that came up were around inclusion of urban Indian health care in the umbrella that the MOU will provide for the creation of new programs. There was also some focus on referred care that while we haven't incorporated that into the MOU itself, there'll certainly be a program or a look that the VA will take as they move forward under the MOU, under the new MOU, which again is just an umbrella for the creation of new programs, for methods for consultation and so on and so forth, ongoing consultation. And I think those are that's the important elements that made it into the new draft of the MOU, was around the inclusion of urban Indians and around the importance of ongoing consultation as we move forward.
So when you talk about the referral, you're talking about the Native veteran going to an IHS facility and then needs specialty care and then has to go back to the VA, repeat the same process again to ensure that they get specialty care, but you're not sure whether that's going to be actually in the drafted MOU or not.
It would be a program that we would report on under the umbrella MOU. One of the issues, and if I can go into some detail on the MOU itself, one of the issues that we found with the 2010 MOU was that many of its provisions we had either fulfilled or we found that they had been overcome by events. And so when we took the decision to redraft the MOU, the idea was to create a broader, more general MOU that would allow us to create new programs underneath the MOU and would satisfy the GAO findings around reporting and targets and outcomes and so on and so forth. So those individual programs will take place and be reported on by under that broader MOU. Did that answer your question, ma'am?
More or less.
Okay.
I just want a short answer and to follow up on this MOU process and how important it is going to be. I want to hear from the VA some assurances that our Native veterans will be at the table with you through that negotiation.
Yes, you have our assurances.
Thank you. Dr. Matthews, also on this, the issue that has been raised about this referral again piece, you said that one of the obstacles, I guess, is that you may lose track of the care of the veteran, mm-hmm. And I don't know. That just seems to me not a really good obstacle, because I think if you're doing the reimbursements and everything that you're supposed to do, you should have track of where the veteran is, whether it's in an IHS facility or within a VA facility. And obviously you've heard the concerns around this and why Many veterans will then just not pursue the specialty care that they need. And certainly from a taxpayer perspective, simply it's duplicative and unnecessary. So can you speak to that?
Definitely can, and it's an excellent question and one that I agree as a clinician. The duplication of honestly how VA has formally handled referrals from any of our partners outside of VA is untenable, especially under the Mission Act. We see ourselves really as a coordinator of care at the bequest of the veterans. So in helping them receive care through the First Nations, through their partners, we definitely see that as the veteran is staying at the center and needing to coordinate that care. I agree that the referral of a veteran back to the VA for repeat visits or procedures is unnecessary, and that we actually hope to find through tribal consultations we can work through those issues. We can develop a referral process that's more administrative so that we can track the issue currently about paying reimbursements, whether that's directly to the community provider or to the tribe themselves. I think we can work through consultation. We do want to take the veteran out of the middle of that. We don't want repetitive services, and I think we can move to really support the tribes through establishing appropriate referral guidelines, actually, as was discussed during the first panel. I admit that prior to now, it hasn't been streamlined, but as you guys have given us the authority to consolidate the community care programs and simplify those processes, I think we have a real path forward.
And as you try to wrestle with that, will you wrestle with the copays also?
Oh, definitely. I think that needs to be acknowledged. We currently do not charge copays for veterans being seen under the reimbursement agreements. It's when they have to return to the VA or are seen in community care, they are charged a copay. But no veterans seen under the reimbursement agreements are charged copays.
We don't believe that the veteran should require the copay in the other circumstance.
Understood, and I commit to looking into that issue.
Thank you. My time is up. Dr. Dunn, you're recognized.
Thank you very much, Madam Chair. Most of the witnesses have cited concerns regarding specialty care, referral care, and I want to address that thing. Let me see if we back out of the weeds a bit and ask some basic questions. I think this is to Mr. Smith. You tell me if I'm wrong. Does the VA accept referrals for VA specialty care made by the IHS and THP?
I'll defer to our VA colleagues on that question.
And I'm sorry, Dr. Dunn, just to clarify, the question of referral coming from the...
So from the IHS
Yes.
for specialty care to the VA, are those patients accepted?
Those referrals are accepted. I can't necessarily speak for every facility's procedures at this point, as they are currently being streamlined as to whether or not they may require a visit, but those referrals are accepted.
So is that only for veterans or for any patient from the IHS?
For
veterans in the VA. So
veterans in the
you
VA,
got
yes.
patients in the IHS,
Right.
and they get referred for specialty care to the VA. If they're a veteran, they're accepted by the VA.
An enrolled veteran, yes.
If they're not a veteran.
No.
So that's interesting to me, because when we were in the service, I mean, we treated the Army, we treated the IHS patients no matter whether or not they were veterans. Is that something that's gone away?
That's not something that's currently included within our reimbursement agreements, no, sir.
So is the VA, all right. Things have changed since I was on active duty, apparently. So how well coordinated is the Mission Act, use of the Mission Act with the IHS referrals to the VA? So can the VA then enact the Mission Act for these IHS patients, the ones they do accept?
Yes, their eligibility can be verified, determined, and the veteran then, of course, has choice based on their eligibility to opt in or out of community care.
So they get straight through the system as good as the system is, right?
Right.
All right. So that's an interesting thing. All right. Well, I will yield back with that, Madam Chair. Thank you.
Thank you, Chairman Brownlee, for holding this hearing and for allowing me to join on the dais. I was very lucky to serve with many Native American Marines in Iraq, And I know firsthand the patriotism and bravery they have shown in service to this nation, not just in their current conflicts, but in past. That's why, as chairman of the Subcommittee for Indigenous Peoples, it's been very frustrating to see over and over again how our federal government is failing Native Americans and Native veterans, namely that our trust and treaty responsibilities are not being upheld. Ms. Matthews, yes or no question, are you familiar with the federal government's unique trust responsibility where it concerns Native Americans?
Yes, I am.
Great. Then you will also know that providing Native Americans with health care free of cost is part of this legal trust responsibility, the authority for which rests in the treaty powers in Article 2 of the U.S. Constitution and is confirmed in numerous laws and Supreme Court decisions. Between 1778 and 1868, the U.S. ratified almost 400 treaties, many of which explicitly guaranteed tribes health care in addition to all proper care and protection in return for the seizure and occupation of their land. I have 3 examples of such treaties with me right now that I'd like permission to enter into the record in case our witnesses would like to consult them later. Ms. Matthews. Thank you. Ms. Matthews, given this well-documented legal responsibility to provide health care to Native Americans free of cost, would you agree that it is a breach of our trust responsibility to charge cost-sharing payments to Native veterans when they receive care at the VA? And we've had this discussion going on prior to this.
I would agree it's an issue that we need to look into, as we do currently charge copays.
Okay. So with what I just told you, so would you agree that are we violating that trust then? I know you're going to look into it. I heard you say that before, but do you agree that we're violating our trust responsibilities in that case?
I would agree that VA is following its own regulations to charge copays. We don't currently have an exception on the books.
But the highest regulation there is are treaties approved by Congress. So I'd hope you would actually understand that and send it back to your leadership. Moving on. Ms. Matthews, given this well-documented legal responsibility to provide health care to Native Americans free of costs, would you, skipping forward, myself and sovereign tribes think it's a pretty clear violation, and that's why I'm introducing the Native American Veteran Pact Act to prohibit the VA from charging co-payments to Native veterans in line with our treaty obligations. While I'm thankful for all the witnesses here, and I know this is not an easy subject, I know it involves a lot of jurisdictional issues, I am disappointed that the VA Secretary and the Undersecretary for Health, the leaders that actually signed that MOU that impacts Native veterans' ability to receive care, declined to attend today's hearing. Instead, Ms. Matthews, you are accompanied by the Director of your Office of Rural Health. As a representative for Phoenix, Arizona, it is home to one of the largest urban Indian populations in this country. I'm concerned about the VA's lack of attention to urban Indians in the MOU. And despite over 70% of Indigenous people living in urban areas today, and I do use the VA for services too, so I physically will see this, there is no program office responsible for ensuring that the goals of the VA IHS MOU reach urban Native veterans. So just 2 more questions. In what specific, Ms. Matthews, in what specific ways is the VA prepared to strengthen a new MOU when it comes to improving access to care for urban Indian veterans?
So I'd have to defer actual questions about the MOU to Dr. Klobuchar, but before he speaks, we are definitely committed to working closely with the urban Indian health organizations and even enrolling them, as some of the questions earlier, under the Mission Act into our new networks. We truly believe in working with these organizations.
Mr. Klobuchar, Dr. Klobuchar.
And the current state of the draft MOU includes mention of urban Indian services in the text of the MOU. And Mr. Smith, do you want to make any comment on that?
Yeah, I think the most important point about the MOU is it really is the expression of how our federal agencies intend to collaborate to achieve these goals. Where we do have heard most of the areas of confusion arise are some of the goals around executing some of the new authorities, such as reimbursement authority, for example, equating that reimbursement authority to the MOU itself. So the goals of expressing ourselves as federal agencies and our mutual goal to collaborate together is not the same thing as entering into a binding agreement to reimburse for certain services. And so we're trying to make that distinction as we go through this.
Thank you, and I yield back my time.
Thank you, Mr. Gallego, and thanks for being here and advocating, and also thank you for your service to our country. So, well, there are no other members here for further questioning, so before I conclude, I know, Ms. Birdwell, we didn't ask any questions of you, but I recognize and the committee recognizes the good work that you have been doing and accomplished. So we thank you for that, and we thank you for your service.
Thank you, Chairwoman. I appreciate that.
So, and I want to acknowledge the good work that you and the Office of Tribal Government Relations have done to facilitate the relationships between tribes and VA and the Office of Community Care for facilitating reimbursement agreements. As been already said, but over 10,000 Native veterans have received culturally competent care in their tribal or IHS program and been relieved of potentially grueling and dangerous journeys to the VA. This is critical to ensuring veterans aren't hesitating to pursue treatment, and the work of rural health is certainly not lost on me. Your research and grant programs are important, but you are 3 offices with specific responsibilities solely to Indian country, and we need the same kind of focus for veterans who live in our cities and urban areas. The MOU to improve Native veterans care was not specific to rural tribes or Indians receiving care on reservations. It was to improve all Native veterans' health status. These veterans must be a priority in every program office, and that must be led by VA leadership. You 3 alone cannot direct the services and programs necessary to improve Native veterans' health status across the board. This new MOU, which is going to be extremely important, will be approved by the Secretary and signed by the Undersecretary. So you were part of the institution and not part of its leadership, but we are going to count on your leadership to convey to the Secretary and to the Undersecretary everything that has been raised here today and what will be important from our perspective and for our Native veterans across the country, what is important to them to be in this MOU. And we've heard a lot today regarding Ms. Halen is not here. She had to leave to go to another committee hearing, but I'm sure if she were here, she would be asking about the advisory committee and how important that will be as we move forward. Co-pays, reimbursements of services, duplicity of services, urban Indian services, these are all issues that we hope are specifically addressed in this MOU as we move forward. So I am going to count on you to pass that along, and I want to assure you that this committee will be watching closely. This is extremely important to us. We know we have a long journey ahead. We've made some progress, but we still have a lot of work ahead of us to do. And so, as I said, we'll be watching closely, and I thank you all for being here. Appreciate it very much, and I will ask if the ranking member would like to offer any closing remarks. Well, without that, I again thank you again for being here, and with that, all members will have 5 legislative days to revise and extend their remarks and include extraneous materials, and so without objection, the subcommittee stands adjourned.